the public and governors joining us today. We've had a very busy morning already, covering a variety of different issues. We had a follow-up on a discussion we had on children in crisis with our McGregor Ward colleagues this morning. We also had a long session on equality and diversity, a session on the care home market, as well as a discussion about the bed review, which is ongoing, and importantly had a very long session on staff wellbeing and our staff wellbeing strategy. So the board have already been quite busy so far today. Pretty standard of agenda today, but comprehensive. To go on mute. Some colleagues aren't on mute. Could I ask everyone to go on mute first of all, please? So we'll start off. I don't think we've got any apologies of absence, have we, Sarah? Okay, great. So any new declarations of interest, please let me know if you've got any new declarations of interest by raising a digital hand. Okay, I can't see any digital hands raised. So the last set of minutes, was everyone happy with the accuracy of the minutes held on the 6th of October? Please raise a digital hand if you'd like any amends. Okay, I can't see any amends, so I'll take those as an accurate record and duly sign them. And the matters arising, if we go to page 18 of the pack, the first was to bring the medical revalidation report into the November board. We're talking about that a bit later, so thank you, Charles. Then on the integrated performance dashboard, to invite 2 members of the BAME network who'd been allocated places on the National RES programme to attend a future workshop. Gertie, are colleagues joining us today, or is that going to be in the future?
That'll be in the future, Chair, and we'll pick up the issue around the RES programmes under Glenn's update on EDI. Okay, super, thank you. Then in terms of operational capacity plan and the winter plan and the front door review, we'll come back to that in the integrated performance dashboard. Thank you, Harkinel. So look forward to that. And then on the monthly safe staffing report, to establish how many times the Bluebell unit had to close due to staff shortages. Fiona and I spent a night on the maternity wards last week. Fiona, do you want to give us a verbal update on this point?
Actually, I hadn't prepared those numbers because I did actually give board update last month, and so that action had been closed. But I from memory, I haven't got it today. There was about I think there was 15 episodes or occasions where we needed to close the Bluebell unit, and I gave board assurance that always the last resort that we have as part of our escalation, but sometimes is required from a maternal safety point of view.
Yeah, nice. Thank you, Fiona. And then Glenn, to keep the board appraised regarding progress on the pathology network. Glenn.
Yeah, I actually have a pathology stakeholder board meeting on Tuesday of next week, which will be the first in a long time. So I'm looking forward to discussing the issues that the board has raised with them, and I'll feed back to you after that.
That would be great, thank you. So we look forward to an update at the next board. Then in terms of the monthly safe staffing report, the executive team to ensure that non-clinical staff be reviewed on a quarterly basis, and that will be ongoing, thank you. Then we talked about, which we did, as I've mentioned, Fiona and I and Sue Whelan Tracy joined us for a further board toward evening visits. That was done last week. And then Sophie and Kim to review the risk profile regarding the increasing costs of construction. Any update on this, guys, or are you just keeping a watching eye?
Yeah, we're due to discuss it at corporate risks on Monday. Okay. So we've got construction risks, but also some revenue risks. Sorry, I'm losing my voice, so you have to bear with me.
That's okay, Kim. Thank you.
Okay, thank you.
And Sophie, is there anything you wanted to add? Because I think it's almost inevitable we're going to get inflation on these items.
Yeah, absolutely. So it's already sitting as a risk on all our projects, but this now would be good to raise that up onto a corporate risk register. So Kim's right, we've got that down for a discussion on Monday.
Thank you. Then on the board assurance framework, Black Swan training to be provided. That's scheduled for next year, so thank you, Anne. And then the staff and wellbeing plan to be included at a board workshop. As I said, we did that this morning. And then to bring back the outcomes of the staff and wellbeing plan, as I said, we did that this morning. And finally, to invite bank staff to take part in a staff story, we've got that scheduled for next month. So looking forward to that. Are there any matters arising that I've missed? Okay, I can't see a digital hand, so we'll move on then. To the winter plan update. Arkanel, how's it going and how are you feeling?
Well, it's going. I certainly don't feel as new as I did last month, so that's good or bad. But yeah, no, it's been all right. Good.
So the winter plan.
Yeah, so I would just share the presentation.
Thank you.
There we go. Hopefully you can all see that.
Yes, we can.
So just to take you through where we're up to at the moment, reviewing all of our schemes and everything that we've put in there, we currently look like we have a potential gap of around 23 beds. So given that a few months ago we started at around 50, 60 beds short, before that was 123, I think 23 beds is definitely a much better place to be, and we continue working through some of our schemes to see what we can do to try and close some of that gap. That said, the scale of the challenge is actually really quite difficult to model this year. We haven't seen the impact of COVID, flu and RSV in the way that we've, organisations have anticipated flu demands before. So this is a best guess assessment of where we are, and we're continuing to review that number based on the admissions that we get and the cases that we see. Compounding some of that challenge are the issues that we're facing with our workforce. And so we've talked quite a bit in various forums around the impact on our staff, not least recently with the impact of schools closing again and the associated staffing issues with that. And then some of the other challenges that we're working through, we talked already around some of the care market stability and making sure that we're working with our partners to push our patients through the pathway as efficiently as we can. In line with that, ensuring that we're communicating with our patients, which seems more important now than ever, especially in the face of some of the challenges that our patients are reflecting back to us, and challenges that they might be feeling out in primary care and then kind of presenting to us and ending up blocking up the system, either at the front end or feeling like they've sort of got stuck. So definitely trying to change the narrative around patients feeling more empowered to say, why am I here, rather than us trying to look at it kind of the different way and telling them when they're leaving, and trying to change some of that that narrative, I think will be really, really helpful. And we've talked quite a bit around the challenges we face on McGregor and more widely some of the issues with the cancer patients that we have here. So that will definitely continue to be a focus for us. Just to share with you some of the bed modelling and monitoring that we did to try and inform where our gap is. This graph shows our seasonal bed occupancy, which is the orange line. On top of that, the blue bit is the COVID occupancy. And the green line is where we were trying to pitch our best case scenario for and where our bed modelling can be. And the purple flecks are actually where we have been. And you'll see that that started to rise over the past couple of weeks. And we've definitely felt that challenge internally. I think the other thing to say is that we don't have the flexibility that we had in 2019, say, because we used to be able to outline medical patients on surgical wards if we knew that they were going home. Given that we are focusing so strongly on ensuring that our green pathway stays sort of intact and we're not compromising elective activity in any way, we've really held the line on not compromising that position. The knock-on then is that you have less footprint to sort of go into in times of extreme pressure. And so I'll continue to pull this graph and share with you if you think that would be helpful, just so that you can see where we're at in terms of the best case and the worst case scenario. So in terms of the actual winter plan, there are 4 key areas essentially that we work through to try and make sure that we have schemes in place to keep our hospital safe and our patients flowing as they should. And I won't go through sort of each of them, but I think the key bit to kind of draw your attention to is the box that sort of says ED streaming. So we'll talk later around, or I'll talk in a minute around some of the issues that we've felt in ED, and you'll hear a bit around nationally around pressures facing ambulance handovers. We aren't immune from that, so it's more important now more than ever to make sure that our streaming services and all of those front door bits that we have in place are working. So recently we've just approved the expansion of our opening hours for the acute assessment units, for our PAU, for our AMU, ensuring that frailty is 7 days a week, and expanding from those opening hours and putting some of that resilience in. So it might seem like a small point, but additional porters in a winter plan is actually a really key bit of making sure that people still kind of move through that system. And it's really important to kind of make sure that we're thinking about absolutely every bit that people, every part that people play in terms of the winter plan, and ensuring resilience there, and moving staff around to kind of respond to some of that. So this is a reflection of our internal winter plan. Clearly we work within the system, and so some of those projects are mentioned within that, and that continues through weekly meetings with the Qs, as well as A&E Delivery Board. So in terms of our next steps, I would say ongoing recruitment is definitely our key priority, and making sure that all those extended hours for the assessment areas that I've just talked to have the staff there that are free and able to support this. Making sure that we reset. So some of you may know that our Flex Ward, Squire Ward, is actually open at the moment. So we're trying very hard to close that, so that we can keep that closed for a couple of months, then go back into it as a true flex and pressure ward. So we are getting closer to that. There's also something around the way that we work internally, and we'll be launching some of those standards and making sure that everybody knows what's expected of them and the part that they play. So Charles is supporting on that, which has been really, really helpful. And there's also work to do internally around just some of that daily battle rhythm and the roles, and clarifying roles and responsibility, ensuring that people are trained. And so today, all of our on-call managers are going through on-call training, for example, just to make sure that everybody's skills and competencies are where we need them to be, and that people have an opportunity to flag if they feel that they're not able to undertake some of these responsibilities. What are we doing to kind of provide confidence and support to them? I've said already that system working is really, really important with this, because we can't do this in isolation. We do have quite a good governance structure in place in the form of regular meetings. We also have access to an emergency winter funding bid. So we're currently working through some schemes that we are bidding for to try and get additional staffing for that. The pot for the system is around 4 million. The list I've got so far is 2.6 million. So I'm sure I won't get everything that I'm asked for, but if you don't ask and all that. The next bit around the PDSA review of effectiveness, I think, is really key. So we're starting some of that work now, just to look at all the schemes that we've got in place. So I've mentioned a little bit around the assessment units. How do we know that they're actually effective, and how do we know that we're putting our resource in the right place? And I think, given that we've got such a challenged winter, it's really important that we do that PDSA ongoing and with our clinicians to make sure that we are putting our resource in the right place. I said right at the beginning that staffing is one of my biggest risks and one of the things that I'm most concerned around. So I think it's really important that we review all of the streams and all the work plans that we have in ED to make and throughout the organisation, to make sure that we aren't putting staff in a place where we might be able to move them somewhere else where it might be a better use of resource. And then overlying all of that, I'm reviewing some of the governance process just to provide additional assurance, to tighten some things up, just to make sure that we are going through our action plans regularly and we have real traction on some of these schemes. So I've already started that, and I'll be able to talk anyone who wants to know outside of this meeting through the very detailed action plan that we have.
Harkin, that's a really good summary and introduction, and I particularly like the 4 quadrants of describing what we're doing, so thank you. Questions and perspectives, Glenn?
Yeah, thank you, Harkin. Mel, that was well explained, because it is a very complex thing, and there is a lot of detail beneath the surface, just to kind of reassure board colleagues on this one. I know we're also working on a 10-point plan internally in terms of some of the things that we need to do to ensure delivery. As you heard me say at the 3 boards meeting recently, this is about doing the simple things well. And there's a kind of marginal gains theory approach to this. One of the things, just for example, one of the things that Fiona's updated me on today is that we've introduced KEFID rapid PCR testing in the ED today, and getting the results back within 1.5 hours is part of that protocol, which will help us to be even more nimble. So we'll just need to keep looking at all of these opportunities to keep the flow going, as well as working with partners to ensure both pre-hospital admission avoidance, but also improving discharge processes. And the analysis we did earlier in workshop on care homes was quite insightful on that one also. So good work by the team. Obviously, we need to focus on this. The ambulance handovers is going to be a real issue over this winter, and we need to ensure we continue our best practice that we've historically delivered.
Yeah, no, absolutely. And I think, just for members of the public, we talked about the November 11th risk of double vaccination requirement into care homes as something to keep an eye on, albeit our friends from Warwickshire County Council gave us some assurance on that. David?
Yeah, mine was just a clarification on the slide that you've done on challenges. Are the colours reg rating, or is it just random? Because I was going to question the some of them perhaps are more bigger risks than others.
No, it's very interesting actually. When I did the presentation, I picked up on that. So they're not essentially reg rated because everything could be red. Everything is as difficult as we make it. So I chanced it, hoping no one would ask that question. So thank you very much, David.
Sorry about that. Sorry about that. But so they aren't reg rated at all. They're
not.
It's just for big. It's okay. Fair enough. Thank you.
Thank you. And Simon?
Thank you, Chair. Harkamel, on your slide in the quadrants, which I agree with Russell's a very useful slide, on ED, we're obviously struggling with ED at the moment to hit our numbers. It's a challenged area for us. How confident are we that the things you're putting into place for ED will actually start to improve our performance on ED as we enter the winter period? And the sort of subset question is, and are we doing anything with the GPs of this world to try and reduce people coming to ED that should be going to their GPs and not ED at all?
Yeah, so if I take your second question first, yes, we are working with the GPs. So I meet with them regularly, and there is a system-wide comms piece that is ongoing to try and get patients, as there always is, get patients to the right place at the right time, and really do what they can to try and inform them to go to sort of the right place. So that bit is definitely there. In terms of your first point, there's a lot more that needs to go into ED as well as the ED streaming. There's the whole piece around ED. So I've alluded to some of the issues that we're having internally with that as our A&E system, nerve centre, and embedding that so that we have the right data going in and we're not shooting ourselves in the foot in terms of what our performance looks like when we know that that's not the case. But these are only parts of the issue. And I think for me, my reflection over the last 4 weeks, it sounds very obvious, but it's incredibly difficult to talk through something when absolutely everything has a part to play. So, Glenn said it best, it is marginal gain. The difference, however, this time, if you compare the organisation or the system to last year or the year before, you had flex in different bits of the system. So, for example, last week, we were absolutely hammered in ITU as an organisation and as a region, to the point where movement was stopped, essentially, between organisations. Usually, as an organisation, SWFT could have responded to that. The problem is that we were compounded then in ITU, as well as ED, as well as our beds, as well as in our care home. And so those marginal gains are really, really important because you can't then drop the ball on anything. And I think that's the point of the plan, that it isn't as simple as saying, right, if we get ED streaming right, then that will solve the problem. It's all of it that has to be there. So I'm assured that we know where to put our efforts. It's just, I would flag, or I would ask people to remember that the scale of the challenge is genuinely unprecedented, and actually that given the system just isn't there. So the consequence of a small part of it falling over is then significant.
Yeah, no, understood. Thank you, Harkamel.
Thank you, Harkamel.
really conscious of the time, and I've got 3 more questions. So can we be quick in the question? I'll put it in the chat box, and quick in the answer. Rosemary?
Yeah, but thanks, Harkamel. Great work that's being done internally in terms of the marginal gains. But if you want to give a message to the public about how they can help us, what would that message be?
It would be to really consider whether you need to come to ED in the first place. It's the same message as every year, and we're not, and it's no different this year. That would be the case.
Thank you, Harkamel, and a very important question, Rosemary. And finally, Charles, and then we'll move on.
Just a quick reflection in that, you know, everybody is under strain in the system, from primary care right through to the care home sector. And I think we should just thank and recognise, you know, the daily effort that's being made to keep things going. Yeah, no, absolutely. I'm very conscious, Charles, that a number of members of the ED department in particular, let alone elsewhere, are putting in many hours of overtime and phenomenal effort. So on behalf of the board, I just want to thank all of the frontline teams for the way they're already working at a phenomenal pace. And as I said at the Wellbeing Conference that Sue Pike organised last week, this winter it's incredibly important that we all as colleagues look after one another, look after ourselves, but hold one another's hands and be kind and civil as we work through what is going to be, as Harkamel said, the most challenging winter we've ever had. With that sort of context, thank you, Harkamel, really great. Keep us brief. Look forward to next month's update. Glenn, over to you for the Chief Executive's report, please.
Yeah, thank you, Harkamel. You've covered off quite a few points from the first section of my report, which is about the discussions we had at our recent 3 boards meeting, which, as I say in here, I always enjoy those meetings. They're a great opportunity for us to share good practice across the group. But we enter a really challenging period, and I quote in my report some of the statistics that have recently come out on urgent care, which are the worst figures for 10 years. I also referenced the comms work that we are doing both internally and externally. So picking up Rosemary's point, there's a Choose Well campaign for the public to go to the right part of the system. And also, I think, to be fair on our primary care colleagues, they're offering, in many cases, appropriate access using digital, but patients choosing still to come to ED to get a second opinion sometimes. And I think we just need to encourage people to understand that we are under pressure and there are easier, more accessible points of contact other than the ED itself. But we will be doing the right things to the best of our ability, and that internal campaign of making sure we keep on top of our game throughout winter will be really important. There's then a section on a review of capital allocations that's going on nationally, which I'm involved in. Hopefully this will be ready in time to influence the allocations for next year. And the key to this for me is ensuring that there is an appropriate fair shares approach to integrated care system so that we get our share in Coventry and Warwickshire of the national pot, but then also that there's a methodology that is fair that allocates that down to the individual organisations within the system. And there's a couple of things in there that are relevant to us. Firstly, our internal depreciation, the size of our asset base. Obviously, we own all of our assets. We haven't got a PFI, so we do need access to capital for ongoing replacement, but then also some recognition of accumulated surpluses. And we've used this as a great incentive for clinical productivity over the years. So pushing for a situation where we are able to say to our clinicians, if you work more cost effectively, that will free up resources that we can reinvest in improvements within reason. So I hope I'm being listened to, and I look forward to seeing the results of that national review coming out soon. And we will then get into a discussion about next year's system level capital allocation. I then refer to the system oversight framework and the single oversight framework that has been recalculated now for the integrated care system. So our integrated care system will get a soft rating of 3. This is in the tradition of 1 being the highest performing organisations, 4 being those that are in special measures. and with various interventions in between in 2 and 3. So it's great to see our organisational level soft rating being at a level 1. We're the only acute provider in the Midlands that will have that soft rating, and it's a combination of quality, finance, and performance. And so therefore we will need to keep on top of our game over this winter, particularly on those performance issues, and to ensure that we stay there. What that means to us is they give us maximum autonomy. We do not need the interventions of regional teams or national teams, and they encourage us to provide support and advice to other organisations. And of course, we already are in that situation with the group arrangement. But obviously, what we found from the group is that we can learn from those organisations that we work with in the group as well. So that's certainly helped us to get to the position we're in. And I'll try and speed up. So I then refer to Acorn House, which is a great acquisition. 5 minutes down the road, we now will have increased training capacity. That will help us to deliver more training for lots of different groups of staff, including our work with both Warwick Medical School and Buckingham Medical School, which is great to see, and that will be operational very, very soon. And is another example actually of creating surpluses and spending them on something that improves the local offer. The Levelling Up Coalition, which Anne is leading on, which is a cross-party piece of work to level up and look at health inequalities and social inequalities. And we will do a baseline assessment of that, and they'll look at the actions that we are setting up. I then give an update on trust strategy, explaining that we'll be doing some engagement work during March through to May, and that will lead to a refresh of our strategy. Our strategy, I think, is broadly still relevant. Obviously, it now is very consistent with the national strategy in terms of integration and place-based working and prevention. But we like to think that we set that stall out before the long-term plan. So our next iteration of our strategy hopefully will be the one that the rest of the NHS picks up in a few years' time also. That's probably, so there's then a piece on the resuscitation team, great stats on SWFT being in the top 5% of the participating hospitals on the cardiac arrest rate. And very last, but by no means least, on the back page, I report on the GEM Award winners, the annual GEM Award winners that were announced at our recent annual general meeting, and they're all explained there, fantastic examples of lots of people actually elsewhere in the organisation who do wonderful things. That's all, Chairman. Happy to take any questions.
Okay, just before we go there, Glenn, I do want you to talk about IT, but for members of the board and members of the public, I do want us just to be efficient as possible. If we can use the chat box for questions and perspectives, that would be great. So we're sort of being efficient. But Glenn, can you, and members of the public can see the chat box. So if you want to see what questions Neds or others are asking and being answered to, please look at the chat box. But Glenn, can you brief us please on the IT situation?
Yeah, thank you for the reminder, Chair. So we face 4 non-concurrent days of industrial action from our IT, some of our IT staff. This links to the unison vote from a relatively small proportion of our total IT staff, so about 17% voted in favour of strike action. This is linked to the transfer of our IT service here and at George Eliot into the arm's length company, which is part of SWFT, which will be jointly controlled by the 2 boards in this new model. The national and regional unions are opposed to such transfers because they move away from core NHS. What we've tried to assure all of our staff is they're still very much part of the NHS family. This is not the start of a process of privatisation of our IT service. We're very proud of our IT service. They provide support to us and also to primary care colleagues. But what we do through this model is strengthen them by putting the 2 teams together, create a bigger career structure There's some financial efficiencies in the model that frees up resource to allow us to invest more into IT. So we're not taking savings out, we're actually going to do more for the resources that we have. And we will also be able to have more flexible employment arrangements for these groups of staff, which will include the possibility of having more commercial terms and conditions, which would attract staff to quite a few vacancies we have in the current model, which is based on national agenda for change terms and conditions. But for those staff who want to retain their national agenda for change terms and conditions, that continues. So in the subsidiary, they can continue to access those T's and C's and NHS pensions. And we've also provided for new staff to have access to NHS pensions and NHS terms and conditions. We also will ensure that the company, which we will jointly control, will be an exemplar employer as we are and George Eliot are. So there'll be staff forums, etc. So it's disappointing that the unions have taken this stance and that some of our staff are concerned. We will work with them. We've risk assessed the impact of the industrial action, which is in a few days' time, and at the end of this month also. We've got contingencies in place to ensure that there's no serious disruption to our clinical services, and we hope to move on and make the changes and demonstrate to staff that this will be something they'll look back on as a good thing rather than something that they're concerned about.
And again, for members of the public, the NEDs, the non-executive directors, discussed again in detail this with Glenn to assure ourselves that in terms of risk and benefit, this was well worthwhile doing. So we've got some questions in the chat box, but any questions the colleagues want minuted to Glenn? I think it's absolutely outstanding that we are rated as the only SOF acute in the Midlands. So my congratulations to the executive directors and everyone in the organisation in that regard. I think it is an outstanding result. And the other thing, Glenn, which I don't think you mentioned, nor did I, in the workshop this morning, we signed off our new research strategy with Warwick Medical School, and it is our intention to build strongly on our historic relationship with Warwick Medical School to increase our research capability and to further enhance the brand of SWFT.
And I certainly intend to talk much more about that next month, Chair.
No, and I look forward to hopefully some good news in that regard. So we'll move on then to the integrated performance dashboard, and if Glenn, you could pick up on the questions in the chat box. Anne.
Thank you, Chair. Just by way of introduction, my commentary just provides detail, highlights the detail from my colleagues' report, and really hand over to them now to explore these issues in more detail.
Okay, that's very brief, Anne, thank you. So we'll move on then to Fiona. So Fiona, over to you. You're on mute, Fiona.
Apologies, first one. So I'll be brief as well, actually, because performance in relation to quality and safety remains strong despite the pressures on the front line, and with the capacity that Harkamel's talked about, falls, the number of falls with harm, the number of medication incidents, the serious incidents remain within our control limits, and a strong performance. And I would just echo what you were saying earlier on, Chair, about supporting the staff, the clinical staff, to maintain that despite the pressure is remarkable. So just thank them there again, just for protecting the patients, keeping focused on quality and safety despite the pressure on themselves. But you can see that performance against the two specifics that we are focusing on this year around children in mental health crisis and safe discharge continues to improve.
Thank you, Fiona. Questions or perspectives, Fiona? Someone's having a scratch. Bruce?
Thank you, Russell. Fiona, I note that, I mean, it's a commendable performance on SIs throughout, and that is really to everyone's credit in the current circumstances in the last 18 months. The one that you note there of including a nasogastric tube insertion just caught my eye, and I don't think we necessarily have the assurance now, but I would very much like the clinical governance group to pick up this, and I'm seeking assurance that we've learned from the nasogastric tube SI that was around 2 years ago in a different ward. Are there cross learnings that we do train in? If not, can we do that? And as we consider the root cause analysis from this one, could we make sure that we spread the learnings to everywhere that they're used in, please?
Yeah, we definitely. Just to give you initial assurance, because you're right that the ESI investigation hasn't been completed yet, but the tabletop review that we do immediately, it is not the same theme as the one that we had 2 years ago, and therefore I'm still assured that the policy changes that we implemented there are robust and in place. But of course, we'll consider that as we go through the investigation.
Thank you, Fiona.
All right.
Thank you. And David's just saying in the chat box that will definitely be picked up. And Sue Whelan-Tracy?
Yeah, thanks, Fiona. Staff are working incredibly hard, and I see that the trends in the I Want Great Care, we've got the addition of cleanliness this month, and I just wondered if you could confirm if a patient's on a ward and there's an issue with cleanliness, we obviously want them to raise it there and then so that we can deal with it. Who should they raise that with typically?
Typically the nurse in charge of the ward. It's their responsibility to make sure that the environment is safe.
Thank you.
All right.
Thank you, Sue. Thank you, Fiona. If we've got no other points, I'll just keep us moving forward. So, Harkamel, thank you for your earlier update, but in terms of the board pack points, what would you like to pull out?
I said before, but just to reiterate, ED performance does remain challenged. We are experiencing significant pressure, just in terms of the demand going through the department, but also in terms of some of our internal flow challenges, compounded by some of the IT issues that we're having with our system. Day case and inpatient levels over the last 4 months have been the highest that we've ever seen in this organisation when you combine non-elective and elective. And I think against the backdrop of some of the amazing work that we've delivered from the elective front, to keep that work going whilst having good turnaround times for our emergency patients is amazing. RTT dropped to 83.7%, but we are still good as a comparison nationally. It's just a flag that from now on H2 will impact on that. So expect for performance to drop, but the H2 update that I put in the pack will explain where we're up to in terms of clock stops and actual patients treated. For the first time in a few months, we actually met the diagnostic standard. So 99.1% of our patients received their diagnostic within 6 weeks. So that's amazing, especially when you consider that our waiting list is the highest that it's been since September 2019. Cancer referrals are still increasing, and we saw record numbers of referrals in August for some of our tumour sites, and performance did dip in August, but we did expect that with the patient choice impact of going on holiday. But we also had a record number of treatments that we delivered, so it's important to note that it's a steady position, and we have a good grip on that. Okay,
great. Thank you, Harkamel. Some questions coming in the chat box for you, Harkamel. Just before you answer those, though, just one from me. Do you think we're using the capacity and potential of Stratford Hospital to the extent we should?
When you consider the staffing that we would need to increase what we could do out there, yeah. We know that we would need to enhance our medical cover out there to put anything and to increase the activity out there, and we just would have to dilute this site so much that actually I think it at this point would be counterproductive. Okay,
great. Thank you, Harkamel. I thought that was the answer. I just wanted to get into the public domain. Glenn?
Yeah, just on our performance on elective recovery is really good. The system performance as well. So I think we just got to be ready for our waiting times to potentially plateau or get worse, though, because we will be probably expected to offer mutual aid to some other systems around us where the performance is significantly worse. We are in the process, though, looking at how we can expand our capacity into the future, and particularly how we can protect elective capacity. And the announcements last week around additional capital for the NHS provide opportunities to do that. So we're in the middle of that thinking at the moment, and that's something we can bring back to board. We're very conscious of the fact that whilst we have the Stratford site and it does give us some protection of elective activity, it is much more efficient to deliver elective activity on this site. And I'm sitting here at Warwick. We're looking at how we can facilitate that and also deal with some of the backlog maintenance issues around day surgery. So a plan that the board will probably see quite soon on that.
No, great. And we talked about other than ready capital projects, I think, at the Council of Governors Roundtable. And finally, Rosemary, then we'll move on.
Yes, Kamal, obviously great to see the activity keeping up, but obviously disappointing we didn't quite meet the accelerator figures for the month. What's your thinking on the second half of the year, whether we'll achieve?
So an early indicator for October, the target is 89%, and we have achieved 81% already, and we still have a couple of days of validation to go, so that position will improve. We did expect to dip in September. We knew that it is always harder to take people in September, and this was no different. And we also had pulled forward so much resource to meet it in July that actually we asked people to stagger their annual leave in August and September, and they did so. So, I'm quite comfortable with that position. Moving forward with H2, we've already developed a really robust system to try and track that daily, as we did with the accelerator in the first half, and we're sharing that with the system. So to be able to say to you today, we're at 91%, that's a really assuring position, I think, to sort of be in, to know where we are. And I have confidence that we do have some opportunity in that. I think as a system, there is also opportunity when you consider the volume of clock stops in 2019 compared with now, and how different organisations, like the counting arrangements, will certainly help us. But certainly internally, there is a lot of opportunity, and we know where to concentrate our efforts.
No, great. Thank you, Hark.
Make sure all the ICS are able to deliver as well.
Yeah, no, absolutely. Thank you, Rosemary. Okay, team, shall we move on then? Series of debates going on in the chat box. Again, I'd encourage members of the public to look in those as well. Gertie, for your update, please.
Thank you, Chair. I'll just very briefly run through key highlights. Recruitment rate remains challenging. Arkmal has obviously covered quite in level detail how much of a risk our recruitment is. It remains positive that we have more starters than leavers this month, but we do still have quite a gap in there, and we're looking at reviewing the position for recruitment on the corporate risk register. We've had a very detailed conversation this morning about health and wellbeing, the plans, the strategy and the work that's in place already to support our staff. We saw a slight reduction in the August absence figure rates, but the preceding months were higher than we have seen before that. One of the main reasons for absence is stress and combined musculoskeletal, and there is a significant amount of work being undertaken already to support staff, and we continue to develop that. Particularly, we again focused this morning, for example, on the winter resilience pack to continue to support and focus our staff in those right areas to engage with support. Core skills training and appraisal remains a challenge. It is an area that we had paused throughout the COVID pandemic, and we are now seeking to build trajectories and work with the divisions to improve that, and that will come through the FPE. So I'll leave it with that, Chair, but happy to take any questions.
Thank you, Gertie. Any questions or perspectives to Gertie? I think it's always worth remembering, when we talk about absence rate of around 5%, ours is a bit above that. It doesn't sound so much, but if you do the maths on it, that's 1 day a month, which is 12 days a year, or 1 in 20 of our staff are off sick at any point in time. So the impact it has on the remaining teams is enormous. Any other questions or perspectives to Gertie? Okay, thank you, Gertie. And we had a really good, like I mentioned earlier, Freedom to Speak Up Wellbeing conference last week, and Sue Pike and the organisers of it did a phenomenal job. So if we can just minute our thanks as a board to Sue Pike and her ongoing outstanding leadership of the whole Freedom to Speak Up and equality agenda. We'll move on to Kim. Kim, if you're struggling with your voice, if you can do as well as you're able. If you completely collapse with your voice, I'll get Glenn to stand in. So, Kim.
Thank you, Russell. I think I'll speak quietly, I can manage. So the outturn for the first half of the year is a £26,000 surplus. We've got a paper at the confidential session to discuss the H2 allocations and the impact on the organisation. So we'll have a further discussion on what that means for our outturn position then. Key things I want to highlight is agency spend has been significantly high in month. And that is a cause for concern, but obviously it's in response really to the operational pressures that we are seeing and some of our recruitment challenges. Having said that, the organisation has moved ahead with decisions to go out and substantively recruit wherever it can in order to mitigate the risk of premium costs. The productivity charts, you will note that they look like they're spiking a little bit, but that's really just been distorted really because we've now had the impact of the pay award and the arrears that were transacted in month. So that distorts really some of the graphs. So I need to have a think about what I can do to tell the story a bit better really moving forward on that one. Our cash position remains strong at 34 million. And the other thing I wanted to draw out really is we are continuing to work with divisions around still driving obviously our productivity and cost reductions moving forward in order to stay ahead of the curve moving into future financial years. So the exec team are engaging with the divisions in terms of what their plans are for the remainder of this year as well as next. The last point, sorry, is we continue to work with managing our capital programme in order to mitigate the issue with living within the capital funding limit that we've been set as an organisation. So just wanted to make sure that the board were aware of that as well. Okay,
thanks, Kim, and I appreciate how much you're struggling. Worth also just mentioning that on productivity, the new Finance and Performance Subcommittee met in sort of shadow form, if you like, last week, and you're chairing that, and that will have a big impact. So again, I'm conscious of Kim's voice. If at all possible, if we can pop questions into the chat box, it will help Kim. But Glenn?
Thanks, Kim. Thanks for avoiding me having to go through the finance report. This is probably one that you could bring back to us, but community infrastructure levy and section 106, it'd be good to understand where we are against that trajectory, because every time I walk my dog, I see more houses being built. So it would just be useful to confirm where that income stream is to date and whether there's more potential for that in the future.
I think that's a great call out, Glenn. I'm amazed at how much new buildings are going up around Touchbrook. And Rosemary?
Yeah, so great that we hit our target for the first half of the year. I know there'll be challenges for the second half, but obviously the key challenges are with around the CPIPs, where we've only identified $1 million or so of the 9 million set out here, and potentially it's going to be even more challenging. So I'm just thinking, we made our target, but we only achieved 1 million or so of CPIPs in the first half of the year. How was that? How was that achieved?
Excuse me. A lot of that is around just, I say, fortuitous. You know, we've had a lot of staffing vacancies, although we've actually covered it by using premium costs. You know, so we can actually drive out more, I suppose, in terms of efficiencies, but there's that balance, isn't it, in terms of managing the staff and the impact in terms of their workload. So there's something about moving forward about I suppose, right sizing our services with the workforce that's available, because as we've discussed, workforce is the biggest risk to the NHS moving forward.
Yeah. And it's also the sort of importance of the new F&P meeting. Glenn?
It just reinforces for me the current financial arrangements, the regime we're operating in is not really fit for purpose in the longer run, because we're in effect still receiving top-up funding for some of those COVID costs. So they're topping you up to a break-even scenario all the time, and even trusts that have not delivered any CPIP whatsoever are still being topped up. So I think the sooner we move into next year, we will get back to a situation where I'm anticipating elective activity will be paid for because of the new elective recovery scheme, and that will give us hopefully a better chance of being able to deliver surpluses again, which Kim will be nodding away in the background, but demonstrating that we're still one of the most efficient organisations in the NHS. It's hard to do that at the moment when everyone's just being moved to break even all the time, but our reference costs still indicate that we are.
Okay, great, thank you. And Simon's asked a question about non-paid costs, Kim, in the chat box. If you can answer that, that would be great. We're running a bit behind now, but just keeping things going. Charles, anything on the mortality report that you wanted to raise?
Just that the mortality indicators have remained well in control limits, and the shimmy, although this is very much the rear view mirror, it's quite out of date, but is the lowest that it's been since records began at 0.94. Otherwise, things remain stable. There's one new avoidable death reported, which was a patient who we failed to treat their hypothyroidism. Okay,
thank you, Charles. Any questions to Charles, Glenn?
Charles, one thing I haven't seen for a little while is mortality performance comparisons across the Midlands or nationally. Is that currently available?
With the actual peer comparators.
Yeah, showing how individual trusts are performing against HSMR and SHMI.
We can get that. I'm sure we can get that via CHKS.
Can we put that in next?
Yeah.
That'd be great. Thanks, Charles. And finally, Rosemary, then I'd like to move on.
Yeah, Charles. So we've got a new presentation in the format this month. And I didn't understand one of the points. It says of the 71 deaths to date, 9 had mortality reviews completed by the specialty. Of these, 2 were expected reviews. So what were the other 7? Were they unexpected? I just didn't understand what it meant. And I just thinking perhaps for next month whether they could.
Yeah. Okay. We'll get to
make it.
I think they were expected deaths, but I will get some clarification on that.
It implies that 7 were unexpected, which seems a bit.
Yeah, I agree. It doesn't make, it's not clear. So we'll look at that.
Thanks.
Okay, team. I need to pick up the pace now, please. So the monthly safe staffing report, Fiona.
Yes, this is, thank you, Chair. This is our normal safe staffing report that you see every month that now covers all of the different disciplines, with the exception of non-clinical or medics. The highlights, I guess, in here, it's a 3% gap this month, but that sort of masks difficult days and some difficult areas, which is managed through an escalation process, and the corporate nursing team manage the staffing on a day-to-day basis, particularly in the hospitals. We've undertaken the acuity review, which is done every 6 months, and I'm just working with Kim's team and the other executive colleagues to work through the results of that. You heard from McGregor Ward in the board workshop. That's one of the areas that we that the acuity is higher now than it has been, and therefore there is a need to look at the staffing roster there. The other areas are Feldon, as acuity has gone up, Oaken and frailty. We're just working through whether those costs can be absorbed in their current budget or whether we will need to look at funding that somehow. Other areas of interest or note, you'll see the commentary about maternity and how the recruitment is going in there. It's now a 7% vacancy position, which is significantly improved. Chair, you asked me how the levers and recruitment, and that is a positive balance. That vacancy position is coming down. Obviously a particular area of pressure is A&E, and we have just invested in increasing the nurse staffing in that department as well. So we're busily trying to recruit to those. Other than that, I'm happy to take questions.
Thank you, Fiona. And it's why things like our relationship with Warwick Medical School and our SOF are important to the brand of SWFT, because it makes us a relatively more attractive place to visit, to work for. Questions and perspectives, Bruce?
Thank you, Russell. Fiona, just reminds me, you've included Feldon Ward on your acuity commentary, which is great. And there were a number of other things that came out of the first round of late night shift visits. Yeah. Are those all actioned or in an action plan happening?
They are, Bruce. To be honest with you, I haven't had a chance to put them in an action plan, as in write it up yet. But you captured it all. A lot of the issues we were already picking up. But yeah, the staffing is the critical one. What we're looking at is across the community hospitals, the acuity has actually gone down in Nickel unit and up in Feldon. So I think rather than additional cost, it could be a transfer. So
Good that it's coming in. Good that it's coming out to management review, but let's not lose all the other things from those late night visits. Perhaps we could have a follow up next month.
Yeah.
Thank you.
I know certainly, Bruce. Things like the buzzers were sorted. We've done a check. So we're talking about equipment. We've had a post equipment check, which has gone through, where we found a series of thermometers that boards didn't know they had. And there are some new requests arising as people come up with good ideas, like shoots going down to the A&D for bloods, as I recall, Fiona. So I know Fiona's got it all on her list. Colleagues happy to move on? Thank you, Fiona. So the NED Finance and Performance Committee meeting on the 5th of October. Simon, anything you particularly want to pull out of this?
Thank you, Chair. No, that's the last meeting of the NED F&P meeting, and the only thing, apart from a very good presentation by Fiona on what we're doing to maintain our outstanding status as a trust, which I think would be good to hear more of, I think, as in the public domain, is really a plea about productivity. I think if you look at the numbers, as typically we are seeing income rising, but our costs of personnel and non-pay costs are rising in a linear fashion with the income. And despite all the good work and discussions around productivity, it's not actually dropping through into an improved performance in that area. And I think it just indicates to us that we really need to keep the pressure on that part of the process going forward.
If they're indirect, the percentages should improve. It shouldn't be linear. But I guess, Simon, and just for public benefit, we are, as I mentioned earlier, Kim is going to chair the Finance and Performance Committee going forward, which will effectively be a day meeting where all of the directors are invited to present on their work and their performance and their productivity and improvement plans. And all NEDs will be invited to those sessions, and it's only my expectation Simon and I will be effectively all of those days. So you've got that to look forward to, just as the colleagues in Y have joy in their hearts knowing that at F&P I'm always sitting in the background. Colleagues, happy to move on? Thank you, Simon, for your chairing of that. You've done a great job. The Audit Committee report from the 13th of October, Rosemary?
Yeah, thanks, Russell. Just highlight a few points. Sort of timely with COP26. National Audit Office has recently released a guide for audit committees on climate change, which we discussed in the meeting. And what I think we'll be pleased to hear that internal audit are going to be carrying out an audit of the trust's sort of preparedness for climate risk measures over the coming months. So we will look forward to seeing that. I think the feeling is that whilst moving forward with a committee on sustainability, embedding sustainability within the trust still has some way to go. So I think this will be a useful review coming out. Positive reports in terms of the governance arrangements on South Warwickshire Place, and also risk management at divisional levels will give good assurance there. And the only other point I wanted to bring out was around wheelchairs and the ordering of specialist wheelchairs. There was an exercise, a review carried out, which about the invoicing, which didn't really uncover any problems. But I think what it highlighted to the NEDs was the scale of the ordering of wheelchairs for the public, which is of around £1 million or so per annum. So significant business. And I just we felt that we've asked the new F&P to look at sort of the whole value for money arrangements there, both in terms of how we manage that contract, but also, as we've probably discussed in the past, the whole sustainability, the reuse, and what happens with reablement equipment as well, because these are specialist items which our Ford officer mentioned that some of them are being sold on eBay.
Okay, great, good point. Thank you, Rosemary. Quickly, Glenn, on that, then we'll move on.
Yeah, I was really pleased that you highlighted the sustainability agenda in the report as well, Rosemary. This came up at the George Eliot meeting yesterday, and I think particularly alongside COP26, we turned over the rumour mill to staff this week for ideas on how we can improve our sustainability agenda. But we need to think more about some measures that we can report up to board on this. So that's something that we're going to give some thought to.
Yeah, and to make sure it's not a greenwashing agenda as well.
Absolutely.
Thank you, Rosemary. We'll move on then to the Clinical Governance Committee report for the 13th of October. David?
Yeah, there's only a couple of issues I want to particularly highlight. One was the good work that was done regarding the colposcopy backlog that we identified as a significant risk at our last meeting. I have to say the department did an amazing job to turn it around, within a 4-week period, and effectively have removed the backlog. So many of the concerns that we raised the month before have been addressed. There is still the issue of whether they can continue keeping abreast of the activity. We were reassured that they are. The biggest thing that was raised concern really related to the ambulance turnaround times. We accept that the turnaround times are likely to be longer as the winter goes on for all the reasons that have been discussed earlier. But we were particularly concerned over potential safety issues for the patients that are sitting in those ambulances waiting, because of course they're not actually in the department, and there's a potential for some of them to be actually quite unwell. And so at the next meeting there will be, which is next week, there will be a review of the mitigations that have been put in place, which I understand the ED department have actually worked on to try and minimise the risk to the patients that haven't yet got into the department, because it is a bit of a grey area. They're not quite out in the general public, but they're not in the hospital. But everybody in the world will blame the hospital if something goes wrong to those patients in the ambulances.
Yeah, no, absolutely. Thank you, David. Any questions on for David? Okay, we'll move on then, thank you, to the Patient Experience Quarterly Report, Fiona.
Thank you, Chair. I want to really pull out here two things, and the main one, I want us to celebrate our volunteers. So you'll see on the appendix, we've got the annual report of our volunteer services, and it's an amazing read. And if you haven't read it, I encourage everybody, the public and board members, to read it, because the variety of roles that we support through our voluntary service and the impact that they have on our staff, our patients, our productivity, our efficiency of services is really just comes off those pages. So I think I just want to take the opportunity to say thank you to them all and for their contribution throughout COVID and ongoing and over many years, actually. We've introduced a number of new roles through COVID of support volunteers, companions for dying patients when they haven't got family, home support volunteers, meet and greet, but also welfare call volunteers, and also the 4x4 drivers, and I can keep going, but they're an amazing team, and really want to say thank you. The other initiative that we are progressing this month, which is mentioned in the report but only slightly, but I wanted to pull it out, is the learning disability assistant. We are currently out to recruit for the patient experience team. This is a very specific job description, which is asking for a person with a learning disability to come and support our team to review the experience of our patients with learning disabilities and autism, to make sure that we get it right. It is 6 months funding to do a piece of work around to support us from their perspective. Are we getting it right? So I really look forward to the output of that piece of work.
Thank you, Fiona. As you were mentioning that, and earlier Rosemary was talking about wheelchairs, we've missed seeing Elizabeth, who was one of our volunteers who used to tour the hospital and give us feedback about what access issues were like for people in wheelchairs. I know things are difficult in terms of protocols at the moment, but we need to send a hug out to Elizabeth and say we're looking forward to seeing her again soon. And I think on your point on volunteers, we are incredibly blessed with the volunteers that we have. And I just say to people who are thinking about volunteering, it's a great, particularly if you're retired, it's a great thing to do with your spare time, to give yourself a new purpose, to help others who need help. And my final point on the volunteers, I know Ricarda, our new chaplain, is looking for any volunteers from other faiths other than the Christian faith to help her build up the multi-faith nature of the chaplaincy in the hospital. We have a very good chaplaincy at the hospital, but it is quite Christian focused, and I know she wants to make it a multi-faith chaplaincy. So if there are any members of the public listening now who want to get involved in that, please reach out to Ricarda. So questions and perspectives to Fiona on the patient experience report. Rosemary?
Yeah, again, on the volunteering report, it is such a great report. Can we just make sure that it does get out and is really publicised in all ways possible, whether, you know, communications with the local newspapers, etc., because I think it is fantastic and we want to be able to build on this.
Yeah.
And I think one of the groups of volunteers who aren't mentioned very often are our governors. We are very fortunate to have our governors who work closely with different parts of the organisation to help us deliver the best we can for our citizens. So I'd like to have a shout out for our governors as well. Colleagues, happy to move on because we are running late now. The medical evaluation report, over to you, Charles.
Okay, I'll take the paper as read, but I think there's two things I'd really like to point out in that there is been a considerable improvement in the timeliness of completion of appraisals that are now, you know, well into the 90%. And this has been, you know, consistently delivered. There's also a very thorough audit process that you will see there. We do something called the ASPAT, which is a standardized quality assurance tool, and my colleague Emmett White has done a fantastic job, has actually quality assured all the appraisals this year, so you can see some very robust data on that, and also by and large improvement. With COVID, there has been a period when appraisals were suspended, but also a move from focus of to well-being, and again you can see the data on that, and I think that suggests that there's more to do, as with you know, other groups of staff. But overall, I think it's a very reassuring report, and it shows improvement.
Thank you, Charles. Questions or perspectives to Charles? No, well done, Charles. I think the results are quite remarkable in a year of COVID, to be honest. Okay, so we'll move on then to the Care Quality Commission update, including the insights report. Fiona, what would you like to pull out?
Yes, just to pull out really that it's obviously fairly stable position, and I continue to have regular engagement meetings with the CQC, flagging any risks or concerns, but also telling them about innovations. What I would just flag to the board, it's probably the first time in the insights that the A&E performance indicators have been flagged as a downward trend, which just you know, mirrors what Hogmel and Glenn were saying earlier on, in terms of we really need to make sure that we are improving that A&E performance, but also ensuring that patients are kept safe during these really challenging times.
No, absolutely. Glenn and I received a series of presentations from the George Eliot Directorates yesterday, and the work they've done in A&E is extraordinary under Nadji's leadership. So I think one of the great things about the Foundation Group is the sharing of learning across the different organisations. Questions and perspectives to Fiona on the CQC update? Okay, thank you. So we'll move on then to the Digital Health Board quarterly update. Adam, good to see you.
Thank you, thanks, Chair. Two things I think I'd like to highlight on this report, and the first is the patient portal. So this has been an objective of the trust for quite a long time. It's been part of our strategy, and happily, within the last couple of months, the patient portal has gone live across all of our acute services. So we now have over 20,000 users of the patient portal, which is about 63% of people we've offered it to, which exceeded our original expectation. I think the business case assumed 25% in the first year, and I think that really shows the appetite for interacting with our services digitally. The portal is a catalyst for more transformation in future, and there's more coming over the next few months. We've just added the ability to ask to send patient assessments, questionnaires, and so on. We're adding some features to support patient initiative follow-ups and more flexible care over the coming months. So that's really good news. I think the second thing I'd highlight is the digital hub. So obviously we continue to work with SCC in partnership to look at digital innovation across our services, and the report highlights a number of initiatives we're working on at the moment. I just wanted to highlight the MySense project. So this was our first major initiative in the hub, which back in September was highly commended in the Health Service Journal Awards. We are now looking at scaling up that MySense project and really embedding it in our out of hospital services. So that's really good news. I think the next big digital hub project you'll hear about is wireless patient monitoring, and we are just setting up a trial for that, which we hope to commence over the next couple of months.
Okay, thank you, Adam. Very clear, and these things are happening under your guidance and leadership, so thank you. Any questions or perspectives to Adam? I'm conscious that Danny Roberts has just got a new role outside the organisation, and I'd just like to minute the board's thanks to Danny for his hard work over a number of years to try and get the IT in our trust to the best position possible. So thank you, Danny, and you leave with our best wishes. Sue?
Yeah, sorry to be a bit slow there. Just wanted to recognise and thank you for the work on the portal, and it's really exciting that the new roadmap is coming to fruition, and look forward to seeing when that different functionality is coming in. On the hub as well, we all understand that not everything that starts in the hub makes it out the other end, like my sense, etc. I'm going along there at the end of the month to look at the pipeline and how it's assessed. So just wanted to say, look forward to sharing with you when I get out.
No, great, thank you, Sue. Sound as though you're in prison, being released on day release, out to the digital hub. Joy of joys. Colleagues, happy to move on. And so we've spent a lot of time on EDI, Glenn, including this morning. You're going to give us the update, please.
So this report is in my name because our chairman quite rightly asked me to lead on this, but I won't go through all the content of this report because there is a lot of content, and as you say, Chair, we covered this off in workshop this morning. We're increasingly working with colleagues at George Eliot on this agenda because of Gertie's role spanning the two, but also Wye Valley colleagues are working on things like Civility Saves Lives, which features as part of our group-wide objectives for this year. And we spent time this morning, so I won't spend any more time on the report. Thank you.
Okay, great, thank you. But I can't emphasise to members of the public enough just the amount of time we as a board have put into the whole EDI agenda. It is a journey. We're by no means perfect, but we are certainly, in my opinion, doing our best. Any questions or perspectives to Glenn? Is that a legacy hand, Sue, or a new one?
Actually, I will use it. It was legacy, but I did have a question on this. Really, really pleased to see the detail starting to come out of some of this and some of the high impact areas on 194. Where it says record and monitor recruitment and promotion by ethnicity, gender and disability, I just wondered, will that include or how will evidence be gathered to ensure that if there's any discrimination within sort of promotion processes, because it's not just who gets hired, it's what happens down the pipeline. So I guess it's a yes or no question. Will evidence be gathered through that pipeline so that then it can be mitigated?
Put simply, yes. I mean, obviously, this is based on data, so it looks at applications, shortlisting, and appointments. But we also look at any cases that happen when people are in employment. So all of that data is used. But also, we've got lots of other informal mechanisms that we can respond to, including freedom to speak up, etc.
Great, thank you. And again, just talking about our governor colleagues, I am aware that certainly when it comes to non-executive director recruitment, our governors do have it at the very centre of their thinking, how to ensure that the process of attracting candidates and interview processes address as far as possible issues of EDI and generally making people feel positive about applying, whatever their background. Colleagues, happy to move on? So I think we're then on to the summary of ratified policies. Anne?
Thanks, Chair. So the policies outlined in front in the document already exist, and they've just been updated to take account of changes within either national guidance or guidelines.
No, great. The being open policy sounds good. And any questions on the ratified policies? Okay, duly noted. And then we've got the board committee minutes for noting, the first of which is the Audit Committee on the 8th of September. Rosemary, anything you'd like to add to this?
Nothing to add, Chair.
Thank you. Any questions to Rosemary? Okay, great. Thank you very much. The clinical governance meeting of the 8th of September. David, anything you'd like to add?
No, nothing from me, thanks.
Thank you. Thank you for taking over the chairing of that. Any questions or perspectives to David? Thank you. So I think we're then on to any other business. Is there any other business from colleagues? Could you please raise a digital hand? Okay, I can't see any other business. So questions from governors or members of the public. Sarah, have we had any notified to us?
Roger Lloyd had submitted 2 questions, but I believe these have been addressed by Rosemary and David Spraggett directly and discussing outside the meeting, so no other questions.
Okay, so just for a couple of minutes, would any members of the public or governors who are present on the call would like to raise a digital hand to ask a question now? Okay, I can't see any digital hands being raised. I feel a bit like an auctioneer putting down the hammer. Roger.
Thank you. Yes, Sarah's right. My earlier questions are being dealt with outside the meeting. My only comment was in relation to the designation of Chief Operating Officer and Director of Operations. That seems to me to be a bit tautologous, but is there significance in the different classifications?
Okay, thank you, Roger. Glenn, do you want to answer that for us, please?
So buried within my chief exec's report, you probably saw an update on the titles of executive directors. Over the last few years, a lot of organisations have moved to chief officer rather than director of. So we are making that move, but in the current arrangements, the separation of those titles relates to the fact that Stephen is overseeing George Eliot and SWFT at the moment as the Chief Operating Officer, and Harkamel is acting as Director of Operations. But we'll move to chief titles for all of the board level posts very soon.
Thank you, Glenn. And any other questions from members of the public? Otherwise, I'll draw the meeting to a close. Okay, I hope members of the public have found the chat box interesting to see the different questions that have been asked during the course of the meeting. I look forward to seeing you all at our December board. In the old days of pre-COVID, the chair would often provide mince pies to that final board meeting. Unfortunately, in a COVID world, you have to buy your own mince pies for the last board before Christmas, but look forward to seeing you at the December board, if at all possible. In the meantime, can you please ensure, if you're invited for a booster, to get your booster jab? And secondly, if any people who are listening to this have not yet been jabbed, the thing you can do most to help your loved ones and the NHS at the moment is to get your jabs done and encourage others to do so. Take care, everyone, and thank you. Bye-bye. For members of the board, can I suggest we have a 7-minute break? We get going with the confidential board at 3:30. Thank you.